Hi, my name is Lily Rolfe, and I use they, them pronouns, and I am a fourth year medical student at Rush. I am the curriculum director of the Chicago Trans Health Initiative, and me, along with other wonderful members of our curriculum team, have helped build these workshops for you. I hope you enjoy.
So I'll also be leading the presentation with Lily. My name's Stefan. I'm from UIC. And then another Sean, who's on the call, helped develop the slides, as well as another member of the group, other Lily, who overall we're going to be talking about the surgical interventions portion. I would say the presentation leads kind of from a bottom-up approach, focusing first on the different types of bottom surgery because they're quite in depth, a lot of reconstruction stuff going on, and then working up to top surgery, and then talking a little bit about like facial surgery as well. To start, we'll talk about bottom surgery specifically on the feminine side, and that is vaginoplasty, or the development of a neovagina, which the main approach is called PIV, or penile inversion vaginoplasty. So overall, as I said, it's kind of constructing this neovagina out of already native tissue as well as other tissue from the body, like a skin graft. And the standard approach of the penile inversion vaginoplasty was developed specifically for trans feminine patients in mind. And it's kind of built off of the traditional forms of developing a neovagina. Some reasons that people get this procedure done and is often cited is things like affirmation of gender, physical and emotional comfort with their body, helping reduce distress, a sense of ease while out in society, obviously, and then as well as sexual function and fulfillment. And kind of one of those key benefits of this penile inversion vaginoplasty, and it's like, I guess, development out of the standard vaginoplasty, is that it is incorporating that previous penile tissue, so that like sexual pleasure can be maintained through that tissue because it's being involved in development of like the neoclitoris and all that. So overall, the way we'll talk about the surgery is of the different surgeries is kind of the indications and criteria that are needed, the actual procedures, and then kind of some post-op stuff and some concerns in terms of outcomes to be cognizant of when you're talking to patients, as well as just talking in general in the space about these interventions. So most of the criteria are reflective or universal, but overall, you need to be 18 years of age for the vaginoplasty, have a formal diagnosis of gender dysphoria, that sustained 2 recent letters or referrals from either a physician or a psychologist with a PhD. A lot of times they also require at least a year of continuous hormone therapy as like a prior treatment in terms of like gender dysphoria. And then especially with some of the bottom surgery, a preferred criteria or requirement is doing some pre-op hair removal. This makes it so that it's a little easier to use that native tissue within the reconstruction of these neo organs and structures, so that you're not having to deal with like those hair follicles and having to take them out actually like during the surgery, although that can be done for any like remaining ones. And then a big thing to really consider when coming to the surgical aspect of gender affirming care is really both personal and social support. As with any surgery, there's a lot of recovery that occurs, and that incurs a lot of time, money, energy, and support from those around you. At least for the penile inversion vaginoplasty, patients are usually in the hospital for up to like a week because they typically have to go back to see if any wound dehiscence starts occurring and kind of doing revisions at day 7. So that's pretty extensive. So having personal support of someone that can be with you in the hospital and all that, as well as then when you're getting home and still recovering from that surgery, is really important. So having a good social network and support is paramount when going forward with these. So overall, the technique is quite complex, but if you want to think about it in different like stages of surgery, there's testicle removal, so orchiectomy, deconstruction of the penis so that that penile tissue can be incorporated into the new structures, as well as a very important part is urethroplasty, since the urethra obviously has to be maintained and kept from the penis and incorporated into the neovulva. That's a big portion of the reconstruction so that patients are able to void properly. So for orchiectomy, as mentioned, removal of the testicles occurs. And this is just kind of a visual description of that. The tissue that you see kind of with the blue line being cut out can be utilized within the preceding surgical stages, but mainly what you see on the right is that the testicle is exposed and then removed. And then you kind of have that surgical field open at that point, so you're able to then go through deconstruction of the penis. So taking the skin and some of that tissue off so that it can be used to form like a neovestibule or the surrounding area within the vulva or neovulva. And then the glans penis, which is the head of the penis, can be utilized and kind of, as you see in this right image, some of those structures kind of internalized and then situated as a neoclitoris. And then that skin can be used around. On the right image, as you can see as well, so that's like a Foley catheter in the middle that's keeping the urethra patent. You can then properly place that within the neovestibule as well. This is where some of that penile tissue, as well as potential graft that you get from like a forearm or anywhere else, can be used to form the neovagina. And so basically what they do is they take a mold or a form and they wrap the skin kind of inside out, so that the layer that's able to adhere within like the space that they carve out to create the neovagina is able to adhere, and then it essentially acts then as the cavity that will form the neovagina. As you can see in kind of the second image from the left, they attach it to that native tissue from the penile deconstruction. And so that's where some of those sensory tissues are able to be utilized, as well as mentioned the neoclitoris that was formed from the glans penis is where you can get that sexual pleasure and function for these patients. So that's sometimes one of the key things of why getting surgery is able to maintain that sexual health while still being affirmed in their gender and their body. And then on the right, you can see the tissue is also then kind of used to form the labia, both a labia minora and then a neolabia majora on the outer portion where they're placing the sutures. So overall for post-op, as I mentioned, it's pretty in-depth. Patients are there for a little bit after the surgery for any revisions and monitoring, but kind of the key mainstays of post-op management are antibiotics because infection risk is high. Then patients also have to go through a pretty rigorous vaginal dilation therapy involving sessions of like 15 to 30 minutes daily for several months using different dilators that go up in size to kind of decrease the risk of stenosis or kind of like closing off of the neovagina, because it isn't a native space. The body isn't necessarily sensing or acknowledging it if it's not being regularly used. And that's something that's carried over from other previous surgeries and development of management of like Mullerian dysfunction in patients that need like neovagina built as well. Once that initial dilation therapy is done for a few months, if patency is successful, then patients can kind of gradually decrease the dilation therapy, or if they're regularly having penetrative intercourse with partners, that can also be utilized as a way to maintain the neovagina. Cleansing is also important in that those early stages, as we think about that high risk of infection, hygiene is quite important. So certain people will use water versus like an actual iodine solution while the healing process is occurring to kind of make sure that this neovagina is staying clean, because often people talk, at least in like OB-GYN, about like self-cleaning with like a native vagina, but with this neovagina, they don't necessarily have those physiological functions built in. So this washing is important with that. So for the outcomes portion, I just cited some recent studies that talk about these, and you can kind of see some similarities in the issues. What stood out to me, obviously, was the stenosis or stricture of the neovagina. So that's why that dilation therapy is really important. Wound dehiscence, so that's kind of the falling apart of the wound after surgery. That's obviously a big issue and why they keep patients in the hospital or nearby for follow-up. And then you can also get a lot of urogynecologic issues. So issues with incontinence, voiding, and urethral stenosis. So having these patients plugged in with urogynecologists is kind of an important portion of this. And I think an important thing to think about in the future of OB-GYN is the involvement of those subspecialists. And the second study showed similar things. Like voiding dysfunction was one of the big outcome issues. So that's overall our overview of the penile inversion vaginoplasty. So this is what I like to see as our interactive intermission. I wanted to talk about kind of how you can find and record the sexual orientation and gender identity for a patient, which is called a SOGI form, at least in Epic, and other big electronic health records. And it's something that's actually been required since about 2018 for EHRs to include. So I just kind of made a very brief case presentation based off of a training module in Epic. So a patient named Ash, they use she and they pronouns, as a 32-year-old female, no past medical history, obviously, besides being like trans and going through gender affirming care. And they recently underwent penile inversion vaginoplasty, and they're following up with their PCP 1 month later after their surgery. The clinician was excited to see them and update her medical records to reflect additional steps towards her gender affirmation goals. What do you think the clinician could do next to properly document this information? And there are a few things that you can do, but obviously the title of the interaction kind of gives it away. Maggie, great point. That was something I was going to bring up in the next few slides when I show the form. But yes, patient comfort and autonomy in choosing how it's documented is very important. I will say, obviously, if the patient's undergoing this treatment at a surgical center and has notes written about these surgeries, I would imagine they'd be okay with it being put. But if for some reason it was like at a separate institution and they had someone that had access to their medical records, specifically at like Rush versus UIC, that's definitely something to consider. But yes, Albie said there's a place you can place or list organ inventory. So overall, the main thing is a SOGI form. So the sexual orientation and gender identity form, this kind of goes into the patient's biographic and history section of their record. So looking at, this is an example of it's not a real patient. This is from the Epic Playground. So Ash here, where would I click if I wanted to find this patient's SOGI form, if anyone knows? Up by their name. Okay, that's good. So maybe honing into the top left area. Is there any specific term or portion of the bio, like bubble or breakout here, that you would click on? So it is up here. So you can click on where their gender/sex is listed next to their age. So if you hover over female and clicked on that, it would populate a SOGI form. And if a SOGI form is filled out, I didn't take a picture of that, but if they have one filled out next to female, it would have like a little I indication in a circle, like an info little bubble, and that tells you that they have one filled out. This is kind of what it looks like. I show more of it later, but you can kind of see it starts with the sexuality portion and then goes on to gender. I filled out some portions just for like what a patient might have here, but I think what's important to note for the gender identity portion, and as I think Mary had mentioned, or Maggie, sorry, at the top says, inform the patient that anything entered here will be visible to anyone with access to the legal medical record. That's really important, especially in pediatric patients. Someone chooses to come out to you and you get that privilege, definitely talk to them as an adolescent if they feel safe at home, if their parents are aware, because if they do have access to like insurance records or their MyChart, that's something that could populate. Overall, you end up kind of filling out this portion, comparing like patient's gender identity, sex assigned at birth, pronouns. They also give like the not listed portion, so you can put neopronouns in, and then some affirmation portions. And then we'll touch later on the interactive portion, kind of doing that organ inventory that Albie mentioned.
Destiny asks if SOGI forms pop up for all patients or something that you have to add manually to someone's patient record.
So it's not automatically there unless you create one. You can create one for all patients though, because we all have pronouns, we all have gender, we all have a sex. And so you can create that for a patient if they want, but it's not automatically there. If one is there, it'll put the little icon. And then if you hover over their biographical info, they'll make like a truncated form if you don't want to open the whole form.
And we will acknowledge that we're epic-centric here, but other EMRs do have Soji forms as an option. But I will now go on to talk a little bit about phalloplasty. General plan overview, which is this slide, or in the next couple criteria, very similar to vaginoplasty, the technique, complications, monitoring, and outcomes. Overview, what is a phalloplasty? It's a creation of a penis or a neopenis, typically through a procedure involving a free flap or a pediculated flap of skin. Now, in case you either have completely forgot about your surgery rotation or you haven't had it yet and you're like, what is a flap? So a flap typically is when they try to maintain the blood supply. So in addition to harvesting just I was going to say the meat of the skin, which is not the correct terminology, but instead of just harvesting what they are trying to get, they also make sure to preserve the blood vessels so that they can reconnect them in later, which allows the new neophallus in this case to have a good blood supply and have better healing. So with the phalloplasty, there's typically 2 locations that will harvest it. There's a free flap, which will take typically from somebody's forearm. There'll be 2 free flap locations, one for the neophallus itself and one for the neourethra. So that is something you need to be wary of, because if there's a tattoo here, or if somebody has something where they don't want an arm scar visible, it's definitely something to take in mind. But if you have a tattoo in your wrist and you want a forearm free flap, you might get a tattoo in your neophallus for fun, or you can get a pedicled flap, which is you'd never actually separate it from its blood supply. So you basically take a chunk of flesh from the anterior lateral thigh and kind of rotate it into position, letting it stay connected to its blood vessels so you don't have to do the tricky retying and resuturing of the blood vessels. It's important to note that typically surgeons want a flap that hasn't been overly punctured before. If it has been in the past over some time, it'll be fine. Again, tattoos were allowed. But if you have a patient who wants to seek out phalloplasty and they're doing testosterone injections, it's good to advise them to at least leave some chunk of one of their anterior lateral thighs free of an injection site, just to make sure that if they do decide to seek out phalloplasty, that they have a chunk of non-punctured skin. Why this is, I don't know. I didn't get a super clear answer when I asked, but I was told this was a thing that mattered. In addition to just the creation of the neophallus or the phalloplasty, you can also masculinize the whole perineal area. You can get a vaginectomy to get rid of the vagina, urethral lengthening, or moving things so that you can now pee out of your neophallus, perineoplasty, scrotoplasty, and do things to just kind of change how things look down there. It is important with all gender affirming surgery to have a discussion with the patient to see what they want out of it, because all of these surgeries have different things that they can change a little bit. Or if you want, the appearance of a neophallus, but you don't want, for example, the urethra to get messed around with, you can make that work. That is an option. It's not a super commonly done one, but it is an option. It isn't just a one and done surgery, with all things very informed consent and working with their patients to know what they want. Pre-op considerations. So the requirements and criteria similar to vaginoplasty. Typically, you need to be on HRT for a year. You need the 2 letters. You need the hair removal from the site, especially if you're getting the forearm flap. The neourethra site definitely needs to have as much hair removal as possible, because you don't want hairs growing in the new urethra. Smoking cessation is pretty important. It's not a contraindication, but it is highly recommended, I think, for all surgeries, because smoking isn't great for healing. But again, it's not a contraindication, but highly recommend it. And a big thing for all of these surgeries is the social support. Unfortunately, there's not a lot of surgeons that do this surgery. So people will travel many, many states away. And when they do come to get the surgery finally, they should expect to be in the area for at least a week, probably a week and a half. And it also takes a very long time to heal. So if you have a relatively non-strenuous jobs, you're looking at 4 to 6 weeks before you can go back to work. But if you are walking around, moving around, stuff like that, it's going to be at least a good 2 months before you're back to work. So Not only is the surgery itself expensive, it also takes you away from your job, which is what is helping you get money. The system we live in. So yes, our general operative technique we have some pictures in the next slide, but this is just to kind of give you an idea of everything that can be involved in this. Again, things can change, but the creation of the phallus and an important thing that can be done when you are doing the phalloplasty is that you can also do a hysterectomy at the same time. Sometimes people do it in stages, which we'll go over shortly, but it's a longer surgery, but then you don't have to come back twice. So there are some people who get the hysterectomy at the same time as well. And you can get erectile devices because unfortunately the neophallus on its own is not erectile tissue. If you want to use it for, say, penetration, you will need to get a device implanted. This is the staging. Every surgeon's a little bit different, but if you do a 3-step staging, first stage is basically creating the neophallus, where you take your neourethrocyte, you kind of do it so that the skin is on the inside, and then you kind of hug it around with the skin on the outside with the other flap. If you do from the thigh, it's a little bit different because then you can use tissue from the anterior vaginal wall to create the urethra, so you don't necessarily need a second flap site. So the first stage would be just that skin flap creating the neophallus. Second stage, if you want to do it 2 stages for this, you can do the hysterectomy and the vaginectomy with the urethral lengthening and scrotoplasty. If you do separate it out, this kind of gives the neophallus time to heal on itself before you kind of introduce the concept of having a urethra and stuff like that. But you can do this all in one. I do not know which would make you lean one way or the other. And then typically down the road, once things have healed a little bit, you can start thinking about implants for like testicles or erectile function. So yes, tube within a tube. So that's you have your 2 flap sites, create the neourethra, sandwich it, and then you transplant it to the pelvic area, and you have to reconnect all of the fun little vessels that you carefully preserved in part 1. You do want to, as you see, have it around some sort of catheter just so you can make sure that you maintain patency of the neourethra. Step 2, we have the masculization. This is for the forearm flap, the masculization of the perineum. So you can get the vaginectomy. We'll go into a little bit more depth about that later. Do the urethral lengthening, connecting it all the way to the neourethra after that's had some time to heal, paraneoscrotoplasty, and just kind of giving the appearance of a scrotum that you can later put in testicular implants if you so wish. Which brings us to step 3, which would be just inserting the testicular and erectile implants. There's a whole variety of these. Basically, the TLDR for this is that outcomes, people are pretty happy with them. All of these studies don't have like the highest number of patients, but if you can see, most of them have pretty happy functional ratings or satisfactions ratings, and people report being able to be sexually active. And in general, even though the aesthetic rating is slightly less for that first one, still pretty positive. Complications. So a lot of the complications you'll see are similar to most surgeries. Wound infections, wound breakdown, this can happen. Urinary catheter difficulties, since we are dealing a lot with the urethra. Flap loss is rare, but can happen, which would cause death of the neophallus, unfortunately. Again, it's rare. And then rarely you can get a hematoma or a rectal injury. That would happen typically in the first month, which is why we have pretty close follow-up, and you spend the first week typically in the hospital. Long-term, similarly, you can get urethral stricture, wound contraction and scarring, granulation tissue, and corona, or like the glands of the penis, can flatten a little bit. Since people do frequently get the implants, there also can be some complications from this. So typically you want to do this after the neophallus has plenty of time to heal, but with insertion, it can cause infection. However, this isn't a contraindication to getting a new implant in the future. You just have to remove the implant, let things heal a bit, and then you can insert in a new implant in 6 months. And erosion. So if the neophallus is not of the correct length or something happens, the implant can protrude through the skin or the urethra, which is you just kind of have to yank the implant out at that point. Post-op management, pretty similar. You need to do prophylactic antibiotics while you're in the hospital. You do get to see the urologist for the rest of your life due to the increased risk of strictures. Like, it is something that needs to be monitored pretty closely. There's also the problem of most people needing to fly states and states in order to get this surgery, which means that while you have the first follow-up and within that 1 week while you're in the hospital, you still ideally, if you are in town, would see the surgeon pretty regularly after that for a while. However, we live in the society we do. So if the patient does have at home a PCP who is just like affirming, knows what they're going through, they can do a lot of their post-op follow-up through there. And most of the surgeons I see would like send a picture as like an update to make sure that nothing looks wrong from the outside. It's also important to note that sensitivity will likely be decreased compared to the flap site, and that to get the full sensation that you would be expecting, it can take up to a year to return. Then we have our friend metoidoplasty, or you might frequently called metas in a lot of the trans community. So this is a way to create a neophallus without having the flap site. So it uses local tissue to cuts the suspensory ligament of the clitoris, expands that out, and you can get a like 1 to 3 inch phallus with girth roughly the size of the thumb. You can do a urethroplasty and like move the urethra into this new phallus and then create the scrotum and do a lot of that perineal masculinization that we were talking about earlier. Benefits from this is that since this is like native erectile tissue, you can get erections, and typically the clitoral tissue is still there. So hypothetically, it's more sensation than the forearm flap would be. However, you can't do a implant due to the size. There's too much risk of erosion or snapping. Don't want that to happen. And for some folks, due to the size penetration also might be difficult, and erections might be less rigid. Operative technique like for this. So typically they will obliterate the vaginal cavity. They will detach the clitoris. Luckily, local testosterone gels can help increase the size of the clitoris pre-op, so that can make it larger so that you have more tissue to work with. Also, global testosterone also helps with enlarging of the clitoris. You can then basically turn the labia minora and form like a little urethra around to kind of connect the current urethral exit to the neophallus, and then create a scrotum from the labia majora. Typically, the urethra is 2 parts, the little native urethra, and then the tissue from the labia minora going up to the urethra. Fun fact, there are a couple of things besides labia minora and the forearm flap that can be used to do urethra lengthening, kind of due to skin texture. So for the full neophallus, typically the forearm is used just because it's a larger area. But with the flap, you can use the anterior vaginal wall because it's still kind of that mucosa lining. So that's similar to what is found natively in the urethra. Or if you just need like a little bit more, you can actually do buccal graft. So you can get tissue from your cheek lining, and that can also mimic a similar structure to the urethra. Advantages of the meta compared to the phalloplasty: it's generally a less invasive procedure. It's less visible scarring. It does have similar complications to the phalloplasty without the risk of flap loss, because you're not having to move a whole new chunk of tissue to a new location. And you won't have the coronal flattening because you're just kind of keeping the native clitoral head and just kind of moving it out a little bit. And there's also lower incidence of wound breakdown, infection, and urethral stricture and fistula. Typically, patients are pretty happy with this. They like the aesthetic outcomes. There's better erogenous sensation, and there is a chance for penetrative intercourse. However, with the size, sometimes penetrative intercourse can be a little bit more difficult. Now we'll talk about the vaginectomy colpectomy. I kind of talked about it briefly a little bit in the other things, but we thought we'd give it its own little spot here. So colpoclesis, that would be removing of this, like the epithelial cells of the vagina and getting rid of the lumen, like that cavity. Then there's total vaginectomy, which is and colpectomy, which is where you just take everything out. So colpoclesis was originally done in 1877. So like this has been around for a while. Just a little bit of the history of it. Originally, what they would just kind of do is squish the vagina closed and kind of suture it up and be like, all right, we're done. This was mainly originally useful in like situations where prolapse was a super big concern, but like the tissue is still there, so it doesn't actually really get rid of the vagina. It just kind of prevents things from, in the case of prolapse, kind of snaking back out again. The first time that we've kind of talked about this for the transmasculine population was in 1996. At that time, they basically did a similar thing, but they were able to preserve chunks of the anterior vaginal wall for the urethral lengthening, which is something that we still kind of do today. And then they would leave the perineum open for drainage of discharge from vaginal epithelium, because if there is any of that remaining epithelium there, as we mentioned before, the vagina is a self-cleaning organ. Typically, discharge will happen if you don't get rid of it, which is not something you really want to deal with too much. So nowadays, we do our best to de-epithelialize everything as much as possible. So when we do a vaginectomy today, we typically do a hysterectomy first. We're not going to spend too much time, I think, talking about the hysterectomy, but that would be just removing of like the reproductive organs, the uterus, the fallopian tubes, the ovaries, all that fun stuff. You can do this either transvaginally or laparoscopic, with or without the robots. There is a decreased risk of urethral complications or fistula compared with colpocolysis, which is just that kind of squishing together, which kind of makes sense, because if you squish things together but kind of leave it there, things can get angry and it won't like wear through, and you won't have stuff that is going into the vagina because now the vagina is no longer there. You yanked it out. The two most common reasons for reoperations for this is urethral stricture or fistula. So the technique for it, you typically will use that sharp dissection or with your fun scalpels and basically cut all those fun lines there from the introitus to the vaginal cuff. You'll use the anterior wall flap that I keep on talking about to maintain or create a urethra. You then will fulgurate or use that electrocauterization to get rid of all of the epithelium. You will then close everything up again, kind of cover the previous introitus, and you can then use the bulbospongiosus muscles to kind of reinforce that midline and close things up. Surgical outcomes with a lot of these surgeries in the groin, especially when you're messing around in areas close to the urethra, you got the chance of urethral fistula, urethral stricture, partial flap loss, hematoma, dehiscence, and abscence. They're not super common, but there is a pretty high acute urinary retention rate, or 16%. So definitely something to like mention to your patients and not be too surprised if it happens. Top surgery. Masculinizing chest surgery, or what is colloquially known as top surgery. Basically, the intent is to sculpt a masculine chest, give you the pectoral definition, and minimize your scars as much as possible. There's many different techniques. It's very similar to like mastectomies. I feel like you have a lot more worry about like nipple placement, but with smaller chests, you can just kind of do very little incisions and get as much of that breast tissue out. Nipple grafting is something that you'll see commonly done. So especially with the larger incisions, there is a lot of material. You can basically cut a chunk of the nipple off and move it up to the new pec location. But it's an optional thing and something that you should talk about if anyone is considering this. And if they are like, I don't want to deal with nipple grafting right now, it seems complicated. Nipples can be tattooed on later. There's so many great tattoo artists that can do very realistic looking tattoos. I kind of included this picture here to give an example of something that is called dog ears. You'll see this a lot of something that people are concerned about. Since breast tissue can go like under the armpits quite a bit, if you don't get rid of the breast tissue down there, you can kind of have, if you see in that like chest, there's like the little divots coming out kind of near where the incision is, where there's like the little puckerings. This is like a pre-revision for these dog ears. Liposuction use, like while you're in the operating room in that like under armpit area, is a great way to kind of reduce the chance of dog ears. Although if it does happen, you can do a revision afterwards to reduce those looks. Basically, the incision type that gets picked for you depends on the amount of like mass that you have existing already, with the smaller incisions being typically used for smaller chests pre-op, and the larger incisions for folks who have larger chests. And with some folks, the double incision can actually end up kind of going into like one long incision that like meets in the middle, but still has that curved shape. Post-op, most commonly hematoma infection. Rare cases, the nipple grafts can fall off. And it is an important thing to note to your patients that for the first couple weeks to couple months, they can turn like yellow, but typically that's just because they're panicking that they lost all of their blood supply. And they're thin enough that the blood supply they'll revascularize, and like sometimes you'll get like a sunburn peeling type thing, but like that's not the graft failing necessarily. That's kind of part of the healing process. They'll turn back into non-yellow nipples that look like nipples afterwards. Early reoperation does happen in 4 to 9% of folks. Overall, it's a 12% complication rate. And most patients will require drains and compressive dressings for 1 to 2 weeks. However, this is a surgery where if somebody is living, say, close to the hospital or nearby, they can go home that day if they have good at-home support and they had like their surgery first thing in the morning. If it's an afternoon case, you're probably staying at the very least overnight. And if you're from out of town and otherwise you were staying in a hotel, you'll typically stay in the hospital for a while because you don't necessarily have the resources in a hotel to like manage all of this yourself. Considerations. It's very common to have decreased nipple sensation, especially for the first while. It'll take sometimes, again, up to a year for you to get the full nipple sensation that you are kind of aiming to get to, but it's still likely decreased than pre-op. And also, most of the time, the glands and the ducts that produce milk for chest feeding are removed. So that does kind of remove that as an option for folks. So an important part of the pre-op process is talking about like, are you ever planning on doing chest feeding at all? And if that is a yes, being like, okay, should we talk about when this should be scheduled if you want to get top surgery later after you do that, fun stuff like that. Typically, there is not a need to be on HRT prior to top surgery, but some surgeons require it. So it's surgeon dependent, and like to the surgeon's point, there is a lot of body changes that can happen with testosterone, but also there are a lot of people who don't necessarily want the effects of testosterone, but do want to get top surgery. So I am for not gatekeeping it with HRT.
So that was obviously a lot of information. So we can kind of go back to our patient case. So Ash, brief reminder, they're 32 years old. Oh, I forgot to list. They use she, her, they, them pronouns. Recently underwent the penile inversion vaginoplasty, and they're following up with their PCP who wants to update their stuff. So, we've already gone through and clicked their bio and opened up the SOGI form and started filling out some of the sexuality and gender components. Legal information. So this portion, just a heads up, at least in Epic, this is like stagnant, like not dynamic. You can't change it. It's what is legally put into the system. So in this case, the patient, we're just saying that, they've gone through the process. They've been going through gender affirming care for a while. They've gone through the process of having their legal sex changed, which obviously varies on where you are in the country governmentally. But then if you go into the gender identity portion, you can see that they're trans, which we can click to it, that patient sex assigned at birth. So you see there's like some incongruence. So that would obviously identify that this is a gender diverse patient. And then the patient pronouns. I will say of note, you can click multiple, which is why I chose to place that this patient had multiple pronouns. And I also put that you can click the not listed because if someone uses neopronouns like ZZer, I know is a common one, you have that capability to kind of give what the patient wants if the template does not necessarily fit that. And then the affirmation steps. So this patient is kind of someone that's gone through a lot of it. So all of these are click green, but not all patients would necessarily have that. And then you can always type down future affirmation plans. So if they're going through that process, and so this document can always be changing as you're updating and the patient is meeting different milestones and goals. And so kind of the part I wanted to walk through with people is like organ inventory. So overall, just kind of a view of this from left to right, you're starting with what the patient currently has. Then second column is what was expected or present at birth. And so any differences between that would indicate that they obviously have gone through some gender affirming care. And so that's what's kind of then parsed out on the right. So the third column is surgical intervention. So that's what we care about a lot here in this workshop. And then the final fourth and the most right column there is organs that are hormonally enhanced, and specifically like exogenous hormone in that instance. So for organ inventory, Ash is a trans female that has been on HRT for, we can just say for like years, and they just underwent this PIV procedure, the penile inversion vaginoplasty, but they haven't, we'll just assume they haven't gone under any other surgeries. So overall, as I said, like the organ inventory portion on the left here is kind of where they're at in their current status. Since they've been receiving HRT, so we assume like estrogen, maybe like spironolactone, stuff like that. Some breast tissue is probably developing, so I placed yes. This, as a trans female, they expect them to have a cervix, ovaries, or a uterus. They had the PIV procedure, so they now do have a neovagina, and the penis has been deconstructed, so that would be no. Prostate would still be present though, but no testes, because they've undergone that orchiectomy as like a subset of the PIV surgery. Over to the next column, which is present at birth, that's where you can kind of compare and see. It kind of gives a summary of like what interventions. And so as you can see, you would expect them not to have any breasts or the female GU tract, but they would have penile tissue, prostate, testes. So then when you get over to the next column, so for surgical enhancement, they haven't had like implants placed, so you would say no for the breast in terms of surgical intervention, but they do have the neovagina, and at this point they don't have a penis. So you can also, where the like little paper sheet is to the left of the number, yeah, as Sean indicated, that you can click on it, and if you've used Epic before, it's basically like in the ROS or the physical exam, like dot phrase or like note writer, you can like make a comment, and so you could say like had that PIV procedure, so they clearly don't have that structure anymore. And then for breasts, if they were on HRT, you would assume that that's hormonally enhanced, so you would click yes. So that's just kind of what LB, I think, previously I talked about, like where you can place fill organs. And then if you do click on the bio stuff and not open the SOGI form, this is what will partially be in that truncated form when you're looking at the patient's demographic info, like race, ethnicity, insurance, address, all that. They'll have like a little portion that has a truncated SOGI form that kind of summarizes this stuff as like a list with commas separating the different organ portions. So hopefully that was helpful in terms of kind of how you can document some of this stuff and help your patients hopefully get better continuity in their care and decreasing triggers and misgendering, stigma, incorrect, stuff related to their health. So the final portion is facial gender affirming surgery, or FGAS. Facial surgery is being done by many, many people across society, but it can obviously be incorporated and utilized for gender affirming care for our gender diverse population. It's often been used for feminization historically, but also masculinization procedures are done for the gender diverse community. And it seems one of the less studied forms of gender affirming surgery. The more rigorous reconstruction of top and bottom surgery seem to be more extensively researched academically. So it's a whole host of procedures that can be done, as you would imagine when you think about like plastic surgery and facial surgery that people can get. As mentioned, it focuses a lot on feminization, but masculinization in terms of like brow bone and all that can be done. And we just have some images there on the right for depiction of it. So we didn't fully touch on, like, just delve into how stuff is organized, but WPATH is the overarching society that kind of developed the guidelines for anything related to gender affirming care. And historically, facial surgery was not like grouped in with that stuff. But as of the most recent version 8, which was published the other year, they did incorporate and kind of, parallel or universalize those criteria we discussed previously, like age, the letters of reference, gender dysphoria diagnosis, stuff like that. And one thing to note is like insurance is a big thing for all of these surgeries, but especially like elective facial plastic surgery. And so a lot of surgeons still already were requiring this stuff. So we were just kind of augmenting what WPATH standards of care were already at that time. I know this is like a busy figure, but I just thought it was a good kind of summation of what goes into this facial surgery. And so when you're doing a lot of this reconstructing, and I would say this is the most in depth because it also involves like bone, as Lily can kind of mention. When they have a 3D skull from a rotation they had, seeing gender affirming surgery, which is super cool. But they can do some really cool modeling for patients. Using the different measurements as you see here on the pre-op evaluation, like forehead height, frontal bossing, different angles of the bones, and then working with the patient to kind of develop what their goals are for their surgery, how they want to appear after, and kind of be able to make a theoretical model and imaging for those patients that they kind of can expect what that would look like. Because a lot of this is really hard to describe when you're talking about like shaping and all that of bone, and the different reductions and repositioning. So that uses like the 2D and 3D visual simulation for the patients. Then obviously the procedures, and there's a whole list and hosts of them. And then patients obviously have to go through the post-op assessment, and they have, their complications as mentioned previously. For the next slide, it kind of lists more of, I think in a little bit more digestible way, looking at the procedures. So kind of starting from the top of the face down. So for the brow, you can get brow reduction, augmentation, or lift, hairline advancement, or hair transplant, especially with different hormone therapy, especially like testosterone. Hair pattern can change with hair loss. So that's something that can be discussed, obviously. Facelift can occur, blepharoplasty, lipofilling, so fillers, as well as moving different fat to fill pockets, to kind of give the most ideal aesthetic that the patient wants. And then for like cheek and lip, further like implant lipofilling, shortening, general augmentation, as kind of mentioned previously, like the angles, so reduction of a mandibular angle. You can have different augmentation, so making the jawline more feminine or masculine. And you can actually get like vocal cord surgery, and that's something that I'm sure can be talked as its own like workshop with like speech path and all that. Overall, this area of gender affirming surgery is kind of the least studied, but we wanted to at least show some. So a recent systematic review was able to demonstrate that the feminine facial surgery is safe and has reported some positive outcomes by both clinicians and patients alike. So when you're talking about these gender affirming goals, surgeons or physicians have their own ideas, and then patients have their own, and you ideally want to have them all meet in the middle and have a good outcome. And so some studies were able to show that we have decent evidence that this is indicated and a good option for patients if they want to go down that road. And then complications do occur, and often a lot of that, as we've already kind of discussed, is wound complication, infection. And obviously with the face, you're going to have concern for ophthalmic or eye injury, as there's a lot of sensitive structures in the face, including the eyeballs, as well as bleeding is a big issue. You have a lot of vasculature within the skin, especially in the nose, if you're doing like the different shape procedures and reductions. And I know we had some questions, and one that was sent to me privately, was kind of asking about the structure of surgeons that are performing these procedures. So I would say overall it's plastic surgeons, urologists, as well as some urogynecologists. For your bottom surgery, I would say, I imagine the majority are urologists, but there are a handful of top urogynecologists, so from the OB-GYN perspective, that are involved. One of the most, I would say, like prolific ones is Dr. Ferrando at Cleveland Clinic, which we had some citations of like images and stuff. She does bottom surgery there. She's written like the chapters on gender diverse patient care for like the atlases for the OB-GYN field. UCSF also has a physician like Dr. Wittenberg. But yeah, urologists, ultimately WPATH, like those guidelines are what people follow, but it's still like this field is somewhat newer and less, I guess like the framework is less rigid. So there's not like specific licensing requirements. It's more based on the people's exposure. So you're going to get at these big academic institutions. As Lily had mentioned, like they're kind of scattered throughout the country and people have to travel pretty far to get to them. Those are the people that have the most exposure and therefore the skill set to show to patients like, I feel confident in my skill to give you the outcome you want.